pulmonary function test and the pulmonary hyper and the pulmonary hypertension. Please, Professor Hanan, go ahead.
Yes, دكتور علي. دكتورة سارة, I go for share screen ولا ايه؟
يا دكتور تمام, هو الشير مفتوح.
شير مفتوح. طيب.
I will do about this case next week, inshallah. My case of multiple myeloma, I will discuss, I will give you results next week.
تمام.
Go ahead, Professor Hanan, please.
بسم الله الرحمن الرحيم. هي الشاشة بتقلب اسود, مش عارفة يا دكتورة سارة عندكم برضو؟
لا عادي.
واضحة.
واضحة بس مش عارفة ليه بتقفل.
لا بقت اسود دلوقتي.
something wrong. I'm sorry.
قدام اللاب
طلعت كده ولا ايه؟
اوكي.
طلعت.
طيب تمام. This is a brief summary for pulmonary function test as an introduction to understand some points in the cardiopulmonary investigations for a case of systemic sclerosis. Pulmonary function testing includes spirometry, lung volumes, diffusion capacity for carbon monoxide. Other less commonly known pulmonary function test is respiratory muscle strength, pulse oximetry, challenge test with methacholine, which is not performed up to my knowledge, cardiopulmonary stress testing, arterial blood gases, and exhaled nitric oxide. This is the spirometry, simple office-based. It measures flows and volumes. Volume versus time. It can determine forced expiratory volume in 1 second, forced vital capacity and the ratio between them, between FEV1 and FVC, and forced expiratory flow 25-27. This graph is very important to understand. We breathe in this area, This is the inspiration and the expiration. This is the tidal volume. During the pulmonary function test, we take deep inspiration and then deep expiration. And this is the residual volume or the air remaining in our lungs. So residual volume cannot be measured. This is the vital capacity, deep inspiration followed by deep exhalation. And this is the normal tidal volume. The vital capacity includes the tidal volume and the inspiratory capacity. And the expiratory reserve volume, this is the forced vital capacity. دي الvital capacity كلها اهي. This is the vital capacity. The air trapped in the lung is the residual volume. This is the tidal volume, inspiratory reserve volume, and expiratory reserve volume plus residual volume represents the functional residual capacity. This is the whole or the total lung capacity. These are some terminology and the definitions. The forced vital capacity means the patient, after taking the deepest possible breath, this is the volume of air which can be forcibly and maximally exhaled out of the lung until no more can be expired. This is the forced vital capacity. FEV1 is the forced expiratory volume in 1 second. It is part of the FVC. Then FEV1 is part of the FVC. It represents a majority of the FVC. This is the volume of air which can be forcibly exhaled from the lung in the first second of the forced expiratory maneuver. The ratio FEV1 to FVC, this is a ratio. It indicates what percentage of the total forced vital capacity was expelled during the first second. There are another parameters like FEV3 and the ratio between FEV3 to forced vital capacity, which is not our concern today. The peak expiratory flow rate, it is a flow rate, maximal flow rate achieved by the patient during the forced vital capacity maneuver, beginning after full inspiration. It's starting and ending with the maximal expiration. These are the commonly used. These are not important here. They are not commonly used. This is the graph time versus volume for the spirometry. This is the FEV1. This is the FVC. So we can see that the FEV1 is a part of the FVC. It represents the majority of the FVC. The ratio between them is very important, ratio of FEV1 to FVC. This is the normal spirometry. This is the inspiration, and this is the expiration. This is called the flow volume loop. The flow volume loop is very important when we encounter an obstructive pattern. We need to differentiate if it is related to the upper airway, like the trachea or whatsoever, and the smaller airways or the lung parenchyma. This is the obstructive pattern of the spirometry. We see decreased FEV1 like this, decreased forced vital capacity, both are decreased, and also the ratio is decreased less than 70% predicted. This is the restrictive pattern of the spirometry pattern. Here, this is the restrictive pattern. It is smaller than in the volume. Decrease the FEV1, decrease the FVC, but the ratio is normal or may be increased. We mean that in restrictive pattern, both are decreased, but the ratio between them is preserved or may be increased in restrictive pattern. This is very nice. It represents the ratio between the lung volumes in normal and abnormal states. Here is a young adult. This is the residual volume in blue. This is the expiratory reserve volume and the inspiratory capacity. This is the vital capacity. The gray and the pink is the vital capacity. The total lung capacity is the whole three. The blue is the residual volume. In an elderly man, the residual volume increased a little. This is in geriatric population. This is normal physiological change. The residual volume increased slightly, but the total lung capacity is preserved. In early obstructive lung disease, COPD or emphysema, the residual volume increased, expiratory reserve volume increased, inspiratory capacity increased, which means that the total lung capacity increased. In severe emphysema or COPD, the total lung capacity markedly increased, residual volume markedly increased, expiratory reserve volume slightly increased, inspiratory capacity increased. The net result is the total lung capacity increased. This is obstructive pattern. However, in the restrictive pattern, like pulmonary fibrosis, the residual volume decreased, expiratory reserve volume decreased, inspiratory capacity decreased, which means that the total lung capacity decreased. Also in neuromuscular disease, which represents a restrictive pattern, the total lung capacity decreased, but here the air is trapped, residual volume increased, and the expiratory reserve volume is very minimal, which means that the patient cannot exhale the air normally because of the weakness of the respiratory muscles, and the air is trapped in the lung. As you see, residual volume is markedly increased. This is in the case of obesity. It is like restrictive pattern. The total lung capacity also is decreased, but the residual volume is not much increased as in neuromuscular disease. So this is very important. Total lung capacity markedly increased in obstructive pattern. Total lung capacity is decreased in restrictive pattern. This as regards lung volumes. This is the pattern. The green is the normal pattern. The red is the obstructive pattern. The flow rate is decreased, as we see in the red. Here in the blue, this is the restrictive pattern. The lung volumes are decreased. This graph is plotted between the lung volumes and the flow rate. In the restrictive pattern, lung volumes are small. In obstructive pattern, the lung volumes are increased, but the flow rate due to obstruction is decreased. How to measure the lung volumes? This can be used. This can be assessed using gases like helium, nitrogen wash-out lung volumes, or plethysmography. This is to diagnose the restrictive pattern. This is an advanced test. This is to revise. In obstructive pattern, the total lung capacity is increased up to 120%. The residual volume is increased. In restrictive pattern, total lung capacity is decreased less than 80% predicted. Residual volume also decreased less than 80% predicted. The diffusion capacity is a very important test to prove a restrictive pattern. We use carbon monoxide to determine the diffusion capacity for the lung. It measures the ability of the lung to transport inhaled gases from the alveoli to the pulmonary capillaries. So it depends on alveolar capillary membrane, hemoglobin concentration, and the cardiac output. As we see, it may be affected by alveolar hemorrhage and anemia. How we can use the diffusion capacity, how it can be performed. This is the technique, not easy test to perform. The patient expires all the way to residual volume. It means he expels all the air in his lungs. Then number two, he inspires all the way to total lung capacity, breathing from a supply of test gas. It means he exhales first to residual volume. Then he takes a full breath to total lung capacity using the test gas. Then he holds breath for 10 seconds. Then he expires forcibly. The concentrations of certain gas, which is carbon monoxide here, present in the test gas is measured prior to the test. The initial portion of the final expirate is discarded, and a portion of the remainder is analyzed. Generally, the difference between the concentrations before and after indicates the amount of gas that diffuses through the lungs into the bloodstream. This is how the diffusion capacity for carbon monoxide is done. This is the normal alveolo-capillary membrane. It's very nice. This is a case of pulmonary fibrosis. Here, when the diffusion capacity for carbon monoxide is abnormal, it is decreased in obstructive lung disease, parenchymal lung disease, pulmonary vascular disease, and anemia. So it is decreased in pulmonary hypertension, which is our target in talking about pulmonary hypertension and systemic sclerosis. Then DELCO is decreased in parenchymal lung disease and pulmonary hypertension, and also in anemia because it depends on hemoglobin. However, it is increased DELCO in cases of asthma, in cases of pulmonary hemorrhage. So we see in the cases of diffuse alveolar hemorrhage in any autoimmune disease, the diffusion capacity for carbon monoxide is increased because here is more blood than expected. So carbon monoxide, the diffusion capacity for carbon monoxide is increased. In cases of polycythemia, in cases of left to right shunt. So we see here that when blood is present in amounts more than normal, DELCO is increased. However, it is decreased in two similar cases, as we shall see in systemic sclerosis, in pulmonary arterial hypertension, and in parenchymatous lung disease. This is a case of disrupted alveolar capillary membrane. When we ask for DELCO to differentiate between asthma and emphysema, because as we see here, to evaluate the severity of restrictive lung disease, to evaluate cases of pulmonary hypertension, however, it is expensive. General rules, when flow is decreased, lesion is obstructive. When the volume is decreased, lesion is restrictive. So obstructive pattern, diminution of flow. criterion of obstructive and restrictive disease, FVC decreased in both obstructive and restrictive. If FVC is increased after use of bronchodilator, it is obstruction. If it is the same, it is restrictive. FEV1 to FVC, normally this ratio is 75 to 80% of the vital capacity. It is highly diagnostic of obstructive. How to interpret pulmonary functions? Step 1, look at the FVC if it is within normal limits. Step 2, look at the FEV1 if it is within normal limits. If both FVC and FEV1 are normal, then you do not have to go to any further. The patient has normal pulmonary function test. Then, if the FVC and or FEV1 are low, if both are low, then the presence of disease is highly likely. Which disease? If step 4 indicates that there is a disease, then you need to go to the percent predicted for this ratio, FEV1 to FVC. If the percent predicted for the ratio is 88 to 90% or higher, then the patient has a restricted lung defect. Yani if the ratio is normal, this is a restrictive pattern. Both are diminished, FEV1 and FVC, but the ratio is preserved or even increased. If the percent predicted for this ratio is 69% or lower, then the patient had obstructive lung disease. This is a quantitation for the severity. From 70 to 79, this is mild. From 60 to 59, this is moderate. If from 50 to 59, this is moderately severe. If from 35 to 49, this is severe, very severe, less than 35%. These are some examples. FVC predicted 67%, FEV1 40%. This is diminished. This is diminished. The ratio FEV1 to FVC is also diminished. So this is obstruction. Here, FVC is 78%, FEV1 is 72%. Both are diminished, but the ratio is normal or even higher than normal. So this is a restrictive pattern. Here, the FVC is 119, FEV1 111, and the ratio is 94. This is a normal person. This is a brief about interpretation of pulmonary function test. This is an overview about systemic sclerosis. Dear colleagues, are you hearing me?
Yeah. يا دكتور حنان سامعينك كويس.
ماشي دكتور علي. I know that my dear colleagues, Professor Nad, Professor Bilal, and certainly Professor Ali has covered the topic of systemic sclerosis very thoroughly. And I got benefit very much during preparation of my lecture from the lectures I heard in the sessions of the SCCE. About the brief review I have introduced in the conference of Mansoura, which was a very fruitful conference, actually. This is a very straightforward scenario for a case of 67-year-old female. She complains of tingling, change of color when exposure to cold, skin thickening proximal to the elbows and knees, hyper and hypopigmentation of her anterior chest, anemia secondary to GI bleeding, telangiectasia. She has family history of rheumatoid arthritis. About the serology, ANA is a strongly positive speckled pattern, anti-SCCL70 negative, anti-RNA polymerase 3 positive, forced vital capacity 83 predicted, diffusion capacity 85 predicted. The ratio of FEV1 to FVC normal, echo normal. This is a straightforward case of systemic sclerosis. The difficult situation is with a case like this, the second case. She's a 48-year-old female. She complains of increasing stiffness of her hands. Stiffness we can interpret as any arthralgia, maybe rheumatoid arthritis, maybe lupus, any autoimmune disease in its early stages. She also suffers from painful blanching of her fingers in the cold, which may be a Raynaud's phenomena, may be secondary to an autoimmune disease. She complains of tingling of hands. Tingling of hands may be due to carpal tunnel syndrome. Blood pressure is modestly elevated, and she complains of fatigue. This is a difficult, commonly encountered scenario. You have to know about systemic sclerosis to think during diagnosis of such cases. The etiopathogenesis, it has two cornerstones, vascular features and fibrotic features. Here is the maestro, here is the fibroblast. This is the normal fibroblast. This is the fibroblast of systemic sclerosis. It is called the myofibroblast. The green color and the pink color, it is full of